Now start with this the first and the most important bacteria which is first observed under microscope, and the first disease caused by it is anthrax, a zoonotic disease. The first, what is definition of zoonosis? Zoonosis, it is a transmission of infection from animals to man and vice versa. Now this bacillus, again it is classified into two groups: Bacillus anthracis, positive agent of anthrax, and another one is Bacillus cereus, positive agent of food poisoning or gastroenteritis. Now first see about this Bacillus anthracis, positive agent of anthrax. It is obligate aerobe, gram positive spore forming, and the speciality of this bacilli, it have a non-bulging spores. Generally it is motile with peritrichous flagella or maybe non-capsulated, except Bacillus anthracis which is capsulated. Pathogenic species are Bacillus anthracis and Bacillus cereus. Now Bacillus anthracis. Now this Bacillus anthracis, positive agent of anthrax, it have a great historical importance. This is the Bacillus which was first under observed microscope, and it is the first Bacillus or the first Bacillus which causes anthrax, or the first communicable disease shown to be transmitted by the inoculation of infected blood, and it is the first bacterium which was isolated in a pure culture, and it is the first bacillus which was used for the preparation of first live attenuated bacterial vaccine. Now its pathogenicity. The pathogenicity of this Bacillus anthracis, it is due to the production of toxin. First is this anthrax toxin. It is a combined vaccine. Three fragments are involved in this. First is edema factor, which causes or which acts as a adenyl cyclase and develops into increases host cell CAMP. Second one is protective factor, which binds fragments and binds to the host cell receptors and facilitates the entry of the other fragments into the host cell. And third one is lethal factor. This lethal factor, it causes cell death and acts by cleaving host cells MAPK, that is mitogen activated protein kinases. Now these toxin fragments, they are not toxic individually. They are not toxic individually, but in combination they produces local edema and generalized shock. Now this toxin synthesis controlled by plasmids, and these plasmids, when they loss or the plasmid loss of plasmids makes the strain virulent, and that is basis of original anthrax vaccine prepared by the Pasteur. Now the second virulence factor is anthrax capsule. Now the capsule of this anthrax bacilli, it is made up of polypeptide capsule, that is polyglutamate, and the capsule, it is a plasmid coated which inhibits complement mediated phagocytosis. Now transmission, how the anthrax is transmitted. Now the first and the most important route is cutaneous mode. Now in cutaneous mode, spores entering through the abraded skin. Second route of transmission is inhalation of spores. Most dangerous form of this transmission of this anthrax is inhalation of spores, which causes pulmonary anthrax. And third one is ingestion of carcasses of animals dying of anthrax containing spores, or the ingestion of carcasses of animals dying with anthrax. Now clinical types. The anthrax, it is classified into three clinical types. First one is cutaneous anthrax, pulmonary anthrax, and third one is intestinal anthrax, which is rare, occur due to ingestion of spores from contaminated meat. Now cutaneous anthrax and pulmonary anthrax, what is difference between these two? This cutaneous anthrax is also called as Hyde Porter's disease. It is called as Hyde Porter's disease because the people working in dockyards, they carry the load of skin and hide on their bare back. A pulmonary anthrax, it is called as Wool Sorter disease. Why it is called as Wool Sorter disease? It is generally seen in people working in wool factory and they inhale the spores contaminated in this wool. Now transmission. Cutaneous anthrax, it is transmitted cutaneous exposure to spores. While pulmonary anthrax, it is transmitted by this inhalation of spores. Now, what are the clinical features in cutaneous and what are the clinical features in pulmonary anthrax? In cutaneous anthrax, it produces malignant pustules, which are benign as a papules and develops into painless vesicle, and then it produces whole back necrotic issue surrounded by a non-pitting indurated edema. While in clinical features in pulmonary anthrax, it produces hemorrhagic pneumonia. And in this hemorrhagic pneumonia, how it is produced? The bacilli spread by lymphatics or by the blood. And it produces bacteremia, hemorrhagic mediastinsis, and hemorrhagic meningitis. Now, prognosis. Prognosis in cutaneous anthrax, it is self-limited. While in pulmonary anthrax, it is fatal. Now, bioterrorism. This cutaneous anthrax rarely causes bioterrorism. Now, in pulmonary anthrax, it is the most commonest cause from the bioterrorism. See, this is malignant pustules. Now, animal anthrax. Primarily, anthrax, it is a primarily zoonotic disease. Animals affected, how they are affected? The animal affected, they are herbivorous, cattle, sheep, and less often horses and pigs. Now, infection acquired by congestion or by ingestion of spores present in soil. Direct spread from animal to animal is rare. Presentation, it produces fetal septicemia. Infective material discharged from mouth, nose, and rectum. Bacilli sporulate in soil. Now, animal anthrax. Progressive global reduction of animal anthrax in livestock anthrax due to effective preventive measures. Now, both the endemic and epidemic forms of anthrax, they are prevalent in Andhra, Tamil Nadu border, Oka in Karnataka, and in West Bengal. Now, human anthrax. Human anthrax, its incidence rate, it is highest in Africa, Central and Southern Asia. How it is transmitted in industrial area and non-industrial area. In non-industrial area, non-industrial cases, the people's their exposure in agriculture or agriculture exposure to animals. Now, in industrial area, infected animal products such as hides, hairs, bristles, and wools. Laboratory diagnosis. Now, say it is the most infectious bacilli, or there is risk of infection in laboratory workers, the high risk of laboratory acquired infection. Specimen collection. Now, it depends upon the type of lesions or type of the infection. Pus or swab from malignant pustules, sputum in case of pulmonary anthrax, blood in case of septicemia, CSF in case of hemorrhagic meningitis, gastric aspirate, feces, or food in case of intestinal anthrax, earlobes from dead animals. Adios, amigo. Powering off. Now, after collection of specimen, diagnosis can be carried out by first microscopy. Microscopy में we have to do gram staining. In gram staining, see gram positive large rectangular rods without spores. Spores, they are not generally seen in clinical samples. They are generally seen in cultures. The second step is McFadden's reaction. In McFadden's reaction, we have to do this Gauss polychrome methylene blue, where we will get capsule appear as amorphous purple material surrounding the blue bacilli. Third staining is direct immunofluorescence test. Here we will get capsular and cell wall polypeptide antigens detected by direct immunofluorescence test. It is useful during bioterrorism outbreaks. Third step is Ascoli's precipitation test. It is a ring precipitation test done when sample is received in a putride form and bacilli are non-viable. Now, after culture, we have to see what type of bacilli can be observed in cultures. It is, I have already told you, it is a aerobic and non-phosphidase, grow well on ordinary media. And most important is, basically, first I have told you that sporulation or spores, they are not demonstrated in direct clinical samples, they are demonstrated only in culture, and culture which is incubated at 25 to 30 degrees Celsius, we will get well defined, well types of spores in this non-bulging spores in the bacillus. Nutrient agar, it produces frosted glass-like appearance and also shows this medusa head appearance. What type of growth is produced on this selective media? On blood agar, it produces dry wrinkled non-hemolytic colonies. In gelatin stab culture, it produces inverted fir tree appearance. And on selective media, the most important is plate medium. It contains polymyxin, lysozyme, EDTA, and thallus acetate in a heart infusion agar. The second one is solid medium with penicillin. Penicillin. It produces sting of pearl appearance. So, what type of growth? We have to first see what type of growth is produced by this, and then we have to do for stainings. In staining, gram staining, you will get characteristic of bumbo stick appearance. And the spores, they are generally demonstrated by modified Ziehl-Neelsen stain, that is using by hot malachite green, that is Ashby's method, and 0.25 sulfuric acid using this modified acid fast stain, where acid spores are acid fast. And the lipid granules, they are demonstrated by this Sudan black B stain, also called as Burden's method. Now, molecular diagnosis. Molecular methods में the most important is PCR with specific primers. First one is BAPXO1 encoding protective antigen, and second one is BAPXO2. It is encoding capsular polysaccharide. Now, molecular typing, it is useful for epidemiological studies. MVLA, that is multiple locus variable number of tendon repeat analysis, and AFLP, that is amplified fragment length polymorphism. Now, treatment for anthrax. The treatment for anthrax, the antibiotics recommended are ciprofloxacin, doxycycline plus clindamycin, and or rifampicin for 60 days. Antibiotics for post-exposure prophylaxis, they are ciprofloxacin for 60 days plus doxycycline for 60 days or amoxicillin for 60 days, even if strain is penicillin sensitive. Second drug is Rexibacumab. Here it is a monoclonal antibody that neutralizes anthrax toxin. It is a protective antigen for prophylaxis and treatment of inhalation of anthrax. General control measures. It includes disposal of animal carcasses by burning or by deep burial in a lime pits. Second is decontamination, usually by autoclaving of animal products. Third one is protective clothing and gloves for handling potentially infectious material. Now, immunoprophylaxis. Live attenuated non-capsulated spore vaccine, that is stern vaccine for animals, protective for 1 year. Not safe for human use. Now, second one is absorbed allium precipitate toxide vaccine, prepared from protective antigen, safe and effective for human use, and indicated for pre-exposure and post-exposure prophylaxis. Now, the schedule for anthrax vaccine. Indication: pre-exposure prophylaxis for persons at high risk of exposure. The anthrax vaccine schedule is In case of pre-exposure prophylaxis for persons at high risk of exposure, route is intramuscular and the dose is 0.5 ml dose. Dosing schedule: primary series 1, 0, 1 and 6 months. Booster dose at 6 and 12 months after primary series and then yearly. For post-exposure prophylaxis, following exposure to suspected or confirmed cases, route is subcutaneous. Dose recommended is 0.5 ml per dose, and the dosing schedule 0, 2 and 4 weeks post-exposure combined with antimicrobial therapy.